Hello, this is part two of end of life care. Okay, let's do this. End of life care. Wait, wait, just a moment. Oh no, it should be this. Okay, so I left off from slide. um, so this is where we left off, lesson 33. Assessment measurements. This includes comparing the current intensity of the pain they are experiencing to the worst or least pain they have experienced. The brief pain inventory will also identify the location on the body where the patients are experiencing pain. In addition, the brief pain inventory will probe the patient to characterize to what degree their pain hinders 7 specific aspects of their daily life. The life functioning measured by the BPI includes general creativity, mobility, walking, and running, the ability to work, quality, the quality of interpersonal relationships, general mood and emotional state, sleep, and life enjoyment. Okay. So lastly, the brief pain inventory will ask patients to assess whether their pain is being relieved by drug therapy or other types of pain management. Because of its ease of use and its comprehensive focus, the brief pain inventory is one of the assessments most likely to be employed by pain treatment, to be employed in pain treatment. Okay, the McGill Pain Questionnaire. The McGill Pain Questionnaire evaluates and assesses pain along 3 dimensions: sensory, affective, and evaluate pain. Sensory, affective, and evaluate pain. The questionnaire will also use self-reporting and the patient's description to measure pain. Multidimensional approach. The McGill Pain Questionnaire asks sensory questions such as whether the pain is sharp or shooting, as well as effective questions about how patients feel about their pain, such as sickening or fear. Patients also rate the intensity of their pain. The 3 evaluated dimensions are then rated for a total pain index. Another important aspect of McGill Pain Questionnaire is that it can be used in conjunction with other pain assessments to create a more thorough understanding of individual health. As a result of its multidimensional approach and ability to be used with other assessments, the McGill Pain Questionnaire is also widely used by medical professionals. Neuropathic pain scale. The neuropathic pain scale is another self-complete pain assessment tool. This scale asks patients to read the 8 common characteristics of neuropathic pain, which includes sharp, dull, hot, cold, sensitive, itchy, deep pain, and surface pain. It is believed that the neuropathic pain scale is particularly important for both diagnostic and therapeutic purposes. In additional pain assessments. In addition to the pain screening tools previously discussed, it is recommended by The initiative on methods, measurement, and pain assessment in clinical trials that pain assessments should evaluate six core outcomes outcomes in patients. These outcomes include pain intensity, physical functioning, emotional functioning, treatment satisfaction, adverse experiences during treatment, patient characteristics. The previously discussed pain assessment tools, as well as additional ones such as the phases of pain scale, visual analog scale, and initial pain assessment inventory will incorporate aspects of the six core outcomes. Some of the core outcomes can also be assessed by supportive questionnaires for a better medical assessment. For instance, a patient's emotional functioning can also be assessed by questionnaires like the Depression Inventory. Understanding the dimensions of pain and the core outcomes help medical professionals better understand the necessary components for better treatment. Case study. Greg Johnson is a 56-year-old man who works as a mechanic. Mr. Johnson does not regularly visit the doctor. However, when his employer changes insurance policies, the new provider requires yearly physicals. When Mr. Johnson is informed he must have his yearly physical by August 31st, he makes an appointment for the 25th. Greg is not particularly worried about his coming appointment. He is more concerned about the time he will be missing because he has a lot of work to do. However, Mr. Johnson has been experiencing daily pain in his bones and joints. Mr. Johnson attributes his pain as a part of getting older and the nature of his work, where he must lay on cold floors for hours. As a result, Greg does not think it is important to mention his pain to the doctor. Yet, Mr. Johnson's pain becomes a topic of discussion when he winces in distress and groans loudly after being asked to get on the examination table. Dr. Smith asks Mr. Johnson, "Are you experiencing pain?" Mr. Johnson replies, "Yes, but who does it at my age and in my line of work?" My dad's bones used to crack every day, but he never complained and lived until he was 93. I am a man, I can handle it. Wow. His response. "Mm, how might you respond to Mr. Johnson, given his description of his pain?" Immediately refer Mr. Johnson for labs, acknowledge the difficulty of aging, but note the pain response in his chart. Talk to him about normal pain and conduct a pain assessment. Talk to him about normal pain and conduct a pain assessment. Mm, that's correct. That's incorrect. The answer is to acknowledge the difficulty of aging, but note the pain response in his charge. The case of Greg Johnson provides an example where medical professionals can address some of the stereotypes about pain being a normal part of aging, which is what Mr. Johnson believes. Although Mr. Johnson has been experiencing chronic pain, which can be a sign of disease or injury, he believes it is normal and has avoided treatment. Realizing that Mr. Johnson's self-report of being in pain and observing that he appears distressed, Dr. Smith elects to give him the initial pain assessment inventory to determine the extent of the pain he has been experiencing. After determining that Mr. Johnson is in extreme pain, Dr. Smith decides to take blood work to eliminate the possibility of disease as its cause. One more time. That's correct. The answer is acknowledge the difficulty of aging, but note the pain response in his charge. The case of Greg Johnson provides an example where medical professionals can address some of the stereotypes about pain being a normal part of aging, which is what Mr. Johnson believes. Although Mr. Johnson has been experiencing chronic pain, which can be a sign of disease or injury, he believes it is normal and has avoided treatment. Realizing that Mr. Johnson's self report of being in pain and observing that he appears distressed, Dr. Smith elects to give him the initial pain assessment inventory in order to determine the extent of the pain he has been experiencing. After determining that Mr. Johnson is in extreme pain, Dr. Smith decides to take blood work to eliminate the possibility of disease as its cause. Understanding pain management. An understanding of pain management is one of the most important lessons that can be provided for clinicians in the treatment of patients at the end of life because it is considered to be the central issue for terminal care. Medical professionals often know that many patients have indeed a fear of living with unrelieved pain, and suffering alone is far greater than having a fear of death itself. Yet, despite this knowledge, many medical professionals express that they are unprepared to provide the most fitting care and attention for terminally ill patients and families. The primary areas of need identified include inadequate training and addressing discomfort. Most of the complex needs of end of life care fall outside the realm of typical medical training, and as a result, many nurses and physicians may feel inadequately trained to address them. One survey of medical students found that only 18% obtained any type of formal training in end of life care. Furthermore, over 40% felt ill equipped and qualified to educate other clinicians on end of life care. It should be noted that specific medical specialties like geriatrics, oncology, and intensive care appear to have stronger preparatory programs for end of life care. In opposition, a study of geriatric medical experts suggested that 90%, 97% of physicians believed they were well prepared to care for a terminally ill patient. A related concern to inadequate training for medical professionals is overcoming the personal discomfort of death and dying, which is a large part of working with terminally ill patients. Addressing death is seen as particularly challenging. Addressing death is seen as particularly challenging for medical professionals as their training typically calls on them to save lives rather than to accept death. As a result, losing a patient is ordinarily seen as having failed in their work. There is also personal anxiety that medical professionals may experience when caring for dying patients. In particular, countertransference is seen as a risk, as a terminally ill patient may trigger emotions and professional experience from losing a loved one in their personal life. Because of this, medical professionals often must go through a paradigm shift in how they approach treatment for terminally ill patients. Addressing training needs. Specific recommendations to healthcare clinicians have been outlined to address inadequate training as well as improve and enhance the quality of end of life care which they provide. One of the most important recommendations is to provide care tailored to the individual patient's needs. In addition, it is vital to acknowledge, understand, and appreciate there are many conditions that must be treated to provide enhanced quality of life to their patients, including physical symptoms such as pain, respiratory problems, and gastrointestinal issues, which can lead to fear and discomfort. Multidisciplinary team. It is also important to note that the best care for terminally ill patients incorporates a multidisciplinary team, including not only medical personnel, but also social workers, chaplains, and medical health experts to address the social, cultural, and spiritual needs of those at end of life. Furthermore, the expertise provided by the various members of a multidisciplinary team can also address the questions and concerns of the loved ones of the terminally ill patient. A multidisciplinary team is valuable in not only specializing each area that terminally ill patients need, but they can also provide emotional support to each other during times of stress. Mental health needs. Another recommendation provided to clinicians is to address the emotional and mental health needs of terminally ill patients to aid in improving the quality of end of life care. As previously stated, terminally ill patients often battle depression and anxiety. These conditions can be either the result of their illness or pre existing psychiatric illness. In addition, cognitive impairment is also common with terminally ill patients. Some common cognitive changes and impairments seen with terminally ill patients include them withdrawing, sleeping more often, and shutting out external stimuli, including TV, music, and other people. Confusion and disorientation. Terminally ill patients may also experience confusion and disorientation. Specifically, individuals at the end of life express confusion about where they are, what day it is, and different individuals, including close family. It is recommended that medical professions constantly introduce themselves and give their patients reminders about where they are and what they are doing. These recommendations can be given to family members. Terminally ill patients also commonly experience hallucinations. Integrative therapies. Integrative, integrative therapies. Some of the psychological and psychiatric symptoms of terminally ill patients can be treated with psychotropic medication and psychotherapy. However, there are also some integrative therapies. And how can how do you pronounce integrative?
Integrative.
Sorry. Integrative. Combining allopathic and complementary integrative cancer care. So integrative, combining two or more things to form an effective unit or
Integrative.
integrative. Okay, integrative therapies that have been found to provide comfort and improve the quality of life for terminally ill patients. Massage therapy. Alternative therapies include massage therapy, aromatherapy, music therapy, art therapy, massage therapy. This form of therapy provides comfort and relieves symptoms of pain, anxiety, and restlessness, including insomnia, through the physical manipulation of muscles. A study of 300 hospice patients in the end stage of cancer found that massage therapy provided pain relief and improved their moods. Aromatherapy. This form of therapy uses oils, lamps, plants, vaporizers to help alleviate nausea, fatigue, anxiety, and depression. Music therapy. This form of therapy uses soothing, relaxing music found to relax anxiety and stress in patients. Music therapy has been found to not only promote relaxation, but to trigger memories and improve alertness in terminally ill patients. As a result, music therapy has been found to strengthen family bonds and initiate reflection for terminally ill patients. Art therapy. This form of therapy has been known to provide patients with a channel for inspiring, creative, and imaginative nonverbal communication of their feelings. It is believed that our therapy can help terminally ill patients explore their emotions about dying and alleviate feelings of anxiety and depression. Knowledge check. Match up the description of the alternative therapy approach with the type submit when you are done. So massage provides comfort and relieves symptoms through muscle manipulation, provides patients with an outlet for creative nonverbal expression, uses oils, lamps, and plants to help the alleviate symptoms, uses soothing, relaxing music to reduce anxiety and stress. Palliative care and hospice settings. Although terminal patients can be seen in nursing homes, particularly with elderly patients, hospitals, or in the home, if that is a choice of the patient and family, end of life care is typically provided by means of either palliative care or in the hospice settings. The strengths of palliative care and hospice care are that both provide terminally ill patients with comfort to ease physical symptoms of the disease, as well as emotional and psychological support. However, each has different functions. Hospice. Hospice is a unique form of medical care given to individuals in the final stages of terminal illness. As a result, hospice is typically considered for the more advanced stages of terminal conditions such as certain cancers, heart disease, AIDS, chronic obstructive pulmonary disease, um, several neurologic conditions, Alzheimer's disease, amyotrophic lateral sclerosis, also known as ALS, stroke, and stage renal failure. The decision to place an individual in hospice is usually based on a recommendation by the patient's physician or the interdisciplinary team of health care professionals after they have assessed and made the determination the patient's no longer responding to treatment and their life expectancy is estimated to be 6 months or less. Uh, it should be noted the decision to begin hospice is ultimately up to the patient and their family members. Hospice services. The typical services provided by hospice are visits from nurses who specialize in pain management. Hospice also helps in bathing and attending personal needs of the patient. Hospice will facilitate visits from pastors, priests, imams, or any other spiritual care provider if requested by the patient or family member. Speech, occupational, or physical therapy can also be provided by hospice. In this form of care can also help educate family members of the home to best communicate with their loved ones. An important factor of hospice care is that it concentrates on the family members as the primary caregivers, offering advice and education to best assist them in providing optimum care of their loved ones, hospice care, and family members. As a result, uh, hospice care can provide respite for family members who are primary caregivers, as well as support services such as counseling and bereavement for grieving family members. Usually, these services offered by social workers and available to the family for up to 13 months after the passing of the patient. Hospice also educates the family about the dying process. There are physical changes that can occur in patients during the later phases of terminal illness, which may be frightening if family members are aware of what to expect. Physical changes seen during the final stages of terminal illness have included weakness, loss of sensation, changes in skin tone and color, temperature fluctuations, muscle twitchings, variations in breathing patterns, a decreased ability to swallow oral secretions resulting in a gurgle sound while breathing, decreased blood pressure. Some individuals in their last they are unconscious and slowly slip away, while others are conscious and suddenly die. One important consideration to note is that hearing is typically the last physical sensation to go in dying individuals. So, both family members and medical professionals should be aware that patients can hear them even when unconscious. Benefits of hospice care. Another invaluable service offered by most hospices includes up to 13 months of bereavement and grief services to the family members and other caregivers. These services are of utmost importance in the healing process for many. It should not be surprising that many family members and sometimes medical professionals as well become overwhelmed and have difficulty coping and dealing with the death of a loved one. Typical reactions seen after the death of a loved one include shock or denial, an intense sense of loss and longing for the loved one, and eventual adapting and acceptance. Although these are typical responses seen during the grieving process, grief affects everyone differently. Grieving family members have been known to experience both emotional and physical stress, such as a loss of appetite, inability to sleep, depression, loneliness. After-care bereavement services provided by hospice can help the loved ones of the deceased patients heal from difficult grieving process. Palliative care. In contrast to the hospice, which is only provided when patients are no longer responding to treatment, palliative care can be provided while still aggressively treating a disease. Although individuals who receive palliative care are still classified as terminally ill, meaning they are in advanced stages of disease or illness, they receive comprehensive care concentrated on controlling symptoms relating to pain and suffering, enhancing their quality of life and offering optimal medical treatment. Some specific services provided in palliative care are emotional and spiritual support for patients and families, as well as medication to relieve pain and discomfort. Palliative care is created by keeping more patients out of the hospital and when sought early in the diagnosis. It has been found to decrease depression in patients. Case study. In our previous case study, Greg Johnson had been experiencing chronic pain, which he reluctantly disclosed to his doctor during a physical. After conducting the test, Mr. Johnson's primary care physician, Dr. Smith, refers him to an oncologist. Following more tests, Mr. Johnson's oncologist diagnosis him with stage 4 prostate cancer, which is spread to the bone. The oncologist Dr. Jones does not believe Mr. Johnson would be a good candidate for surgery as the cancer is already in an advanced stage, but states that other treatment options are possible. Dr. Jones suggests that Mr. Johnson and his wife discuss their best options and recommends that they consider palliative care, to which the family appears to be non-receptive. Case response. How would you approach Johnson's reluctance about palliative care? Tell them about the other less helpful alternative treatments. Allow them to express their concerns about palliative care. Reinforce the recommendation and remind them of your knowledge and experience. Correct. The answers allowed them to express their concern about palliative care. Although palliative care can be provided while still aggressively treating disease and has been found to provide support to patients and their families, many people believe it means there is no hope left. Seeing the reluctance of the Johnson family to consider palliative care presents an opportunity for Dr. Jones to educate the family on how it can benefit them and improve Mr. Johnson's quality of life. Challenging decisions. Wait, just a moment. What's happening? Why are the pictures not appearing? Just a moment. Let me just uh, do this. Okay. All right, just a moment. Let me just completely log out and then log in. Oh no, I'm so sorry. I shouldn't have. Just just a moment. Let me go back. Oh no. Oh no, I should have just stayed. I was almost done. Let me just go here. Okay. Now let me continue. End of life care. Lunch course. Usually starts from the very beginning, especially see. So I have to just go through one by one so that I can go on to the next part. It's okay. McGill pain questionnaire, multidisciplinary approach, neuropathic pain scale. All right, I just need sharp, dull, hot, cold, sensitive, itchy, deep pain, surface pain. This was given neuropathic pain scale is particularly important for both diagnostic and therapeutic process. Pain intensity, pain functioning, emotional functioning, treatment satisfaction, adverse experiences, patient characteristics, case study, Mr. Johnson, case response, major reform surgeon, acknowledge the difficulty of aging, but note the pain response in his chart, understanding pain management, primary areas of need identified, including adequate training addressing discomfort. Okay, so now personal anxiety addressing training needs. Wow, so those are the pictures. Multidisciplinary team, mental health needs, confusion and disorientation, integrative therapies, integrative massage therapy, aromatherapy, music therapy, art therapy, knowledge check, provides patients with outlet for creative nonverbal, provides outlet for creative nonverbal, uses soothing music, uses oils, provides comfort and relieves symptoms through muscles and manipulations, palliative care in hospice setting, hospice, um, cure certain cancers. So these are the conditions: heart disease, AIDS, COPD, several neurologic conditions, Alzheimer's disease, amyotrophic lateral sclerosis, ALS, stroke, and stage renal failure. Hospice services, hospice care and family members. Weakness, these are the changes, physical changes, loss of sensation, changes in skin tone, color, temperature fluctuations, muscle twitches, variations in breathing patterns, and decrease in ability to swallow, oral secretions, decreased blood pressure, benefits of hospice care, typical reactions seen after death of a loved one, shock or denial, intense sense of loss and longing for the loved one, feelings of despair and disorientation, eventual adapting and acceptance. Palliative care. In contrast to hospice, okay, I think this is where I left off. Palliative care, 52 of 62. I remember thinking I only have 10 left. In contrast to hospice, which is only provided when patients are no longer responding to treatment. Palliative care can be provided while still aggressively treating a disease. Although individuals who receive palliative care are still classified as terminally ill, meaning they are in advanced stage of disease or illness, You receive comprehensive care concentrated on controlling symptoms relating to pain and suffering, enhancing their quality of life and offering optimal medical treatment. Some specific services provided in palliative care are emotional and spiritual support for patients and families, as well as medication to relieve pain and discomfort. Palliative care is created by keeping more patients out of the hospital. And when sought early in the diagnosis, it has been found to decrease depression in patients. Case study. In our previous case study, Greg Johnson had been experiencing chronic pain, which he reluctantly disclosed to his doctor during a physical. After conducting some tests, Mr. Johnson's primary care physician, Dr. Smith, refers him to an oncologist. Following more tests, Mr. Johnson's oncologist diagnoses him with stage 4 prostate cancer, which has spread to the bone. The oncologist, Dr. Jones, does not believe Mr. Johnson will be a good candidate for surgery as the cancer is already in an advanced stage, but states to that other treatment options are possible. Dr. Jones suggests that Mr. Johnson and his wife discuss their best options and recommends that they consider palliative care, to which the family appears to be non-receptive. Case response. How would you approach Johnson's reluctance about palliative care? Tell them about the other less helpful alternative. Allow them to express their concerns about palliative care. Correct. Okay, next. Challenging decisions. End of life care requires several challenging decisions, which must be made not only by the person diagnosed with a terminal illness, but their family members. A recommendation to make the best treatment decisions for a loved one is to participate in family meetings with the doctor. If palliative or hospice care is being recommended, a consultation can help with the decision on whether that is the best option. It is also recommended that families should help their loved ones in organizing their affairs for the future by making decisions concerning all personal, monetary, health, and legal matters prior to terminal illness. Life decisions. Family members designated to make an end of life decisions must be identified early and comfortable with the responsibility. It is ideal for any decisions specifically concerning who will be responsible for their bank accounts, drawing up a will, living trusts, arranging for powers of attorney, healthcare directives, and making funeral arrangements to be made while family members are still healthy. Living will. Living will is document stating that what medical treatment an individual wishes to have, as well as any treatments they do not desire near the end of life. This is incredibly important because an individual may not have the capacity to express their wish when they are terminally ill. In general, it is known that doctors will provide treatment in most circumstances as they do not want to be held responsible for hastening the death of a patient. For this reason, if there is a medical treatment or situation that an individual doesn't want to undergo for any reason, it needs to be stated in a living will. So their wishes are known if that form of treatment is being proposed for them. Will. This should not be confused with a living will. A will is a document created by a person that describes how their assets and estate will be divided after they die. A will helps to reduce lawsuits by describing a person's wishes when they are living and in their sound mind. Living trust. Living trust is a similar concept. The living trust will detail how an individual's estate will be divided and appoint a trustee to hold all titles and funds to distribute to beneficiaries. Power of attorney, healthcare. This identifies or designates a person, usually called an agent or proxy, to make all healthcare decisions when the patient is no longer capable of doing so for themselves. The power of attorney for healthcare will make decisions about what type of treatment, medication, surgery, discharge, etc., is in the patient's best interest. A durable power of attorney for finances is a document that resembles a power of attorney for healthcare. A power of attorney for finances identifies a person that will make all financial decisions for a terminally ill person when they are no longer able to themselves. These decisions can range from the cost of care to property and matters of inheritance. A financial power of attorney can help avoid court battles by ensuring that the individual's wishes regarding their financial decisions are known prior to their death. DNR orders. DNR means do not resuscitate. Do not resuscitate order is a concept close to the durable power of attorney for that for healthcare. If an individual has a DNR order for either personal or religious reasons, if the patient's heart stops or they stop breathing, no one is to perform CPR. Family members, especially a durable power of attorney, should be aware of any DNR order. It is vital to have a copy of this document signed by a physician placed in the individual's medical chart prior to any treatment. Physician orders for life sustaining treatment form. This form describes the treatment individuals desire. Oh, I need to cut. Well, Zoom's still going, so I'll continue. This form describes the treatment individuals desire in the chance of critical injury or terminal illness. Physician orders for life-sustaining treatment form will describe their wishes in various treatment scenarios, including the need for CPR or other types of resuscitation, feeding tubes, life support, and other kinds of medical treatment or involvement if the patient has no pulse and is unable to breathe unassisted. Both the physician and healthcare proxy must sign the pulse form. Case study. In our first case study, Mrs. Wu was in end-stage renal disease. After continuing to deteriorate, Mrs. Wu's doctor informs the family that a donor has been found, but there is a risk for surgery due to other health problems. The doctor asks the family how they feel about life support and CPR. Mrs. Wu's son said, "Do whatever you have to do to save my mom." However, her daughter counters, "Mom would not want CPR due to her religious beliefs." Oh my God. Which of the following would help most to know about in this situation? Which of the following would help most to know about in this situation? The family dynamics, whether Mrs. Wu has a living will or DNR, Mrs. Wu's current labs. Definitely, that's correct. The answer is whether Mrs. Wu has a living will or DNR. A living will and DNR order are important when there are differences within families between what a loved one wishes for in treatment. When a family does not agree, as is the case with Mrs. Wu's son and daughter, having the patient's wishes documented and understanding who has the right to make the medical decisions will help the medical professional make the best treatment decisions for family and reduce liability. Summary. Terminal illness can present a myriad of needs that have to be addressed to ensure that the person approaching end of life receives the best care to ensure the best quality of life in their remaining days. The needs of terminally ill persons range from the immediate and physical, such as the management of pain and suffering, to psychological, to address feelings of fear, anger, sadness, or depression over knowing that death is near. There are also social needs that are important to address, as most individuals who require end of life care are older adults and are often prone to loneliness. This is not only needed for individuals approaching end of life. Caretakers and family members also face a myriad of emotional and psychological needs. Training medical professionals about the need of terminally ill patients and involving family members in all stages of care is an important aspect of providing the highest level of care for the patients. For patients, family, and medical staff working in end of life care settings. Thank you. You have reached the end of this learning activity. To exit this activity, complete additional course requirements. Click exit course in the upper right corner of this window. You have completed a learning activity. Okay, references and then post-its. Good job. End of life references, desktop. Thank you. End of life references, I think. It's okay. And next is, yes, market complete. Posts. Remember the posts. Oh my god, 10. Okay. I'll record. Oh, okay. I'll continue. Terminally ill clients commonly experience periods of deep sleep, significant personality changes, loss of speech, hallucinations, an inability to cope with terminal illness contributes to non-compliance with treatment efforts. Inability to cope with terminal illness contributes to non-compliance. Yes, if you're unable to cope, you are non-compliant. Which of the following are common psychological needs for individuals at the end of life? Which of the following are common? Anxiety. Which of the following? Oh, just one. Anxiety. This form describes a patient's wishes for various treatment scenarios in the event of a critical injury or terminal illness. This form describes a patient's wishes for various treatment scenarios. Living will. Durable power of attorney for healthcare. Oh my god, I'm always confused between durable power of attorney and living will. Wait, just a moment. Elder abuse. Desktop. Oops. Why is it always confusing? Okay, let me just check the differences. Okay, Finder. Let's go to Finder. I need to find the definition. Okay, a living will is a document stating that what medical treatment an individual wishes to have, as well as any treatments they do not desire near the end of life. This is incredibly important because an individual may not have the capacity to express their wishes. In general, it also is known that doctors will provide treatment in most circumstances, and they do not want to be held responsible for hastening the death of patient. For this reason, if there's a medical treatment or situation that an individual does not want to undergo for any reason, it needs to be stated in the living will. Okay, that's a living will document stating living trust. This is with estate. Okay. And the power of attorney. This identifies or designates a person. So this is the power of attorney for healthcare will make decisions. So this is about the person. Okay. All right. The other one is a person. The other one is a document. That's the difference. I always get confused. This is form. This form. So living will is a form. Patients wishes for various treatment scenarios in benefitically ill terminal illness. Number 5 is typically considered for more advanced stage of terminal illness. So for more advanced hospice, withdrawing, sleeping more often, and shutting out external similar examples of what changes psychological. We're sleeping more and shutting out external. Pain screening seeks to identify which of the following intensity of pain. Pain screening, history of pain, impact of on functioning of pain. Oh, this actually came out earlier. Okay, let me just see if I can find it. It's at the very beginning. Okay, let me see if I can find it. The pain question varies in SSP along 3 dimensions, material, total versus over a period of hours, days, or a week. That's acute, chronic pain. This identifies or designates a person, which is associated with chronic pain. Oh, wait, where's that? Pain. Yeah, pain screening seeks to identify the following. It's here. So what's the answer? All of the above. Yeah, it's all of the above. Fine, right. The answer is all of the above. Pain screening seeks to identify which of all of the above. Next, number 8 can be a risk factor for depression and suicide for individuals at the end of life. So what are the risk factors for depression and suicide for individuals at the end of life? Of course, loneliness. Can be a factor, risk factor for depression, pain, 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 pain. Pain can be a risk factor for depression and suicide. Is it pain or is it loneliness? Yeah, it's pain. A good way for medical professionals to address patient confusion or disorientation includes which of the following constantly introduce themselves when interacting. Hearing is the last physical sensation to go in dying individuals. True. The answer is true. Wow, 80%. Thank you. Terminally ill patients commonly experience hallucinations. And the ability to cope with terminal illness contributes to non-compliance with treatment efforts. True. Visual following are common psychological needs for individuals at the end of life anxiety. This form describes a patient's wishes for various treatment scenarios. In the event, various treatment scenarios. False. Okay. Is typically considered for more advanced stages of terminal illness, hospice, withdrawing, sleeping more often, and shutting out external stimuli, cognitive. Pain screening seeks to identify which of the following of the above can be a risk factor for depression, pain, and suicide. A good way for medical professionals to Address pain, confusion, or disorientation. Those which are following constantly introduce themselves when interacting. Hearing is the last physical sensation to go in dying individuals. True. Right. Okay, evaluating continuing continue education, you need the following learning experience true. Continue you need the following learning experience true. And the following experience true. College fair true. About to fair true. Student that individual needs strongly agree. Visual means current useful, effective, appropriate, activity, what changes your are you committed to participating in this activity? I will definitely practice all the has been in, mentioned in this course. Use of resume and I haven't really practiced in any experience and issues. I love it. Okay, finish. Course complete. View my completions. End of life certificate. Congratulations. Wow, good job, Jen. You did a very great job. Okay, moving on to the next one. Thank you. Zoom. 3, 2, 1.